Hi, everyone. Welcome back to House Healthcare. We have with us today folks from SASH, which is very exciting. Great program. We're going to learn what they're doing, some of the pilots that are happening. We have Molly and we have Liz. I'm going to let you introduce yourselves and then you can get started.
Wonderful. Thank you so much, Madam Chair, and we're delighted to be here. For the record, my name is Molly Dugan. I work at Cathedral Square. We provide, we own and operate about 27 different housing communities, primarily for older adults and adults with disabilities in the northwest part of Vermont. We hosted the chair this summer to one of our SASH sites in Essex, which was wonderful. I'm the Director of Policy and Strategic Directions at Cathedral Square, and I had a previous position, which was the founding director for the SASH Support and Service to the Home model. And I want to let Liz now introduce herself.
That's wonderful. Thanks for inviting us. I'm Liz Genge. For the record, I'm healthy. I just want to be presented out there. Yeah, my name is Liz Genge, SASH director for about 2 years now. Her previous work was at one of our designated housing agencies, Downstreet Housing and Community Development. I live here in Montpelier, and just bringing housing and healthcare together has been one of my passions. So I'm looking forward to talking more about it.
Great. So our plan for what I believe is until 2:00 is to just do a quick kind of grounding in the SASH model, which I know you guys are most likely quite familiar with. It's been around since 2011. The state has provided some funding, so thank you very much for that. But we'll do a quick grounding in that, and then we really wanted to focus on kind of our innovative offshoots from the foundational model, which is this embedded mental health program that we've piloted for about 4 years now, that we're now going to be able to expand across the state. And that's just started, and Liz will talk about that. And then another program we're just piloting, we're in the second year of piloting, which is called SASH for All, which is taking the SASH model and having it serve a more general population, not just primarily older adults and adults with disabilities, but getting into family housing and people with children. So that's the plan. So
Great.
I will get right to it. As long as my thing works. There we go. Okay, so I wanted to just start off with the SASH model. So SASH is a Vermont-grown model. We started piloting it in 2009, and it is truly a partnership model between the Affordable Housing Network and community organizations in all parts of the state. And it's really combining housing and healthcare, bringing them together and making access to all kinds of healthcare and housing supports as accessible as possible. The model is based in nonprofit and public housing authorities across the state. I'll show you a map in a second so you can see the reach. Importantly, the direct services that SASH provides on the ground in housing and to community members is primarily funded by the all-payer model. And I don't need to explain that to you guys, so that's awesome. So that's wonderful. But we also have a smaller amount of state funding to provide the support for the statewide administration, which is what Liz and her team does at Cathedral Square.
And I think funding is about $9 or $10 million for the whole program. Do you know? I think that's the number that gets thrown around.
Less than that.
Less than that?
Yeah.
Okay.
Actually, more about 8.
Yeah, I think it's around 8, but yeah, you're not far off.
Okay, yes, great.
So what's especially special about the SASH model is that we are able to target, by having the model coming out of affordable housing throughout the state, we're able to target low-income individuals and families that many of them have grown up in a lifetime of poverty and have not had the same access to quality food, good education, good environments. And so we're able to provide a partnership with them and really serve a large number of high-risk people at one time. So you get this efficiency because of that. And the model, and you'll see this, is very much focused on using evidence-based programming and practices. So we're not trying to make up something on the fly. We are using, and this is baked into the model, using what has worked either nationally or internationally and bringing it home here. This is our statewide reach, and I looked up where all of you were from, and
You're so good.
is well represented in your areas. I'm happy to say what you'll see is that the housing organizations that operate SASH, the individual housing organizations, they hire the staff themselves. Liz and her team provide the training, the support around quality assurance, the data management, but all of those housing agencies, and hopefully you recognize your local nonprofits on that list, are actually running the program. And that was fundamental to this model from the beginning. It's because we knew the local partners are the ones that understand the culture in their local communities. They have the connections. They're going to be able to build trust with their participants and their residents faster than if, like, let's say Cathedral Square decided to do this across the state. That was not something we wanted to do. Cathedral Square does operate SASH though, however. But then besides the housing organizations, we have formalized partnerships with the home health agencies, with all the hospitals across the state, the designated mental health and special services agencies, as well as a lot of universities where we bring in nursing students and social work students and really have good connections there. So the stars that you see there are all the different housing properties where SASH is operated out of. So there's 140 across the state. A pretty broad reach. So just a quick snapshot of who we're serving through the SASH model. The traditional SASH model is about 5,000 participants in a given year. You can see the data there. This is, again, serving primarily older adults and adults with disabilities. So you probably wouldn't be surprised at the gender difference there, with women traditionally living longer than men. The age range, it's pretty broad age range, 23 to 101, average age being about 73. We're serving primarily Medicare, people on Medicare, but a good percentage of dually eligible as well, Medicaid and Medicare. Importantly, since inception of the model and having it expand across the state in 2011, we've served over 12,000 unique participants. So we've really had a broad reach.
You mentioned, I think you said 5,000 at any one time. So do people come often on the program? How does that?
They do, but it's not a big turnaround because we're serving people that live primarily in elder housing. So
once you're on, you kind of.
you're on.
You're on.
Yeah,
Yeah.
we've got participants who've been with us for the whole 12 years.
Yeah.
Thank you.
But then we do have participants that will move on to a nursing home. We have participants that die, of course.
Yes.
So that's a natural turnover. So just a bit about, getting a little bit deeper into what we know about our participants. And this is where you'll see that the health work that we're doing within SASH. So we have our SASH staff on the ground consists of a care coordinator and a wellness nurse, and then this team of all of different community organizations as well come together. And we do at least annual assessments of our participants. And so we're collecting a lot of data, and we're using that data to understand how best to provide the support and services that folks need. So this gives you a sense, this is statewide, of the different health conditions that those participating in SASH are challenged by. Probably not surprised that high blood pressure is what the largest majority. But you'll see, there's also pretty high percentages with mental health challenges and needs, which will lead us to one of the pilots we're going to talk about next. The fact that the median number of chronic conditions is 7. So our participants aren't just dealing with 1 or 2 conditions, but quite a few. We also do validated health screens within that assessment. So we're assessing for risk of social isolation, risk of suicidal ideation. And, that's not a small number, 12% having suicidal ideation in a given year. Risk of falls, that's probably not surprising. This data allows our staff to work individually with folks because they know, they can drill down, but also to know community-wide of the 100 people or so that I'm working with. If I have this many percentage that are falling, I need to make sure I'm bringing in evidence-based falls prevention programs. I need to make sure I'm bringing in diabetes management programs if I have a large percentage that have diabetes. So this is really about serving not just like individual acute, like episodic things, but serving the whole population. So it's very prevention-based in that way.
We
And
do, we
Liz.
collaborate a lot with the Vermont Department of Health, which has been wonderful. And I just wanted to show some of the results that we've been seeing. This is illustrating our work with them on chronic conditions related to hypertension. So this is a 5-year grant that was from the CDC on hypertension. And what we we have cohorts of participants, about 800 individual over the entire 5 years, and just working really specifically to reduce hypertension. Of course, we have the clinics in the community rooms. We know people's blood pressure. We take people's blood pressure. The wellness nurse works with them specifically. And it's amazing how year after year after year, we're really seeing positive results in controlling hypertension compared to the national data as well as our state. And
Yeah, and I want to make sure, because I think this can be a little confusing at first when you look at this chart, because I thought, oh my gosh, this looks like SASH rates are worse than
Right.
national rates. So I want to be clear.
controlling is good.
Yeah,
You
this is
don't-
controlled high blood pressure. So it's people that have it under control either through the work we've done with them on their diet and exercise or their medication management. So it's they have a diagnosis of hypertension, but it's in a range that's now it's controlled and they're not, they're staying ahead of it. So I wanted to be clear about
Yeah,
that.
no, that's a good, I was reading it the same, like,
Like, no, you're not doing so well, ladies.
That's impressive.
Yeah, get back to
Thank you
work.
for saying that.
Yes.
On your last slide, I didn't see anything around, you just mentioned medication management, but I didn't see anything around substance use or misuse. Although you have chronic pain up high there, can you speak to whether you guys do anything to connect folks to those services or you do?
Great. Go ahead.
We do. We do have in our assessment, we do screenings for all of those things as well. We just pulled out a few to highlight what we've been doing. And yes, we certainly do. And we're going to talk more further on about how the mental health clinician is within our teams and how we look at that.
Yeah, we do screening specifically for older adults on alcohol use. There's a validated screen that's specific for older adults because the amount of alcohol that older adults can, you can't drink as much and not be impacted as you get older. That's the science. So we have very specific assessments on that. And we
Related to your risk of falls, which is, I see one of your top concerns.
Well, and that's why having this data is so useful to the nurse and to the coordinator, because they can see, okay, this is a person that does have some substance misuse issues. And look, they're at high risk of falling. It helps you kind of figure out what support they need. So yeah, it's a great question. Okay.
Do you have a question?
Me?
Yeah.
No.
Okay.
Okay, so I want to keep us moving along. So we wanted to talk next about one of our, so we've been at SASH now since 2011. We did get it was evaluated by a third-party evaluator funded through Housing and Urban Development and the Federal Health and Human Services. And that was over 5 years, was proven to not only improve the health and well-being of our participants, but it showed statistically significant reductions in Medicare and Medicaid spending for the folks that were in SASH compared to other folks living in subsidized housing without SASH. So we have a great evidence base at this point. And what we thought was, well, how can we build off of this? Because it's working well within our local communities. We've figured out the delivery mechanism by having this statewide organization do this. And so one of the first things that we had been hearing about from our staff and honestly from our participants was the challenges around mental health. And so we thought, what else can we be doing? So we worked with to get funding from One Care Vermont and started this embedded mental health program that Liz will now talk about.
Yeah, so 2 of our properties in the Burlington area, we embedded a mental health clinician. We've now updated the name to the SASH Emotional Wellness Clinician. She is from the Howard Center, and luckily she's been the same clinician it's actually been 6 years at this
Wow,
point.
that's great.
Yeah, and just so, and we've been tracking some data that we'll share with you. But she's on the sites. She spends her time in 2 different sites, has her office in both places. She works with people one-on-one. She does groups. She does education. And, there's no billing for her time other than being able to be there and present. And we'll look at who she has touched over the last 6 years.
Next slide.
Yeah. So you can see just from the beginning, it's 2017. These are the emergency department presentations of the specific participants that live in the 2 buildings.
Okay.
The blue building is called Thayer House. And so in the beginning, it was 80, 85 per year. And so we've been tracking it. It's our data. And we get pinged, our nurses, our wellness nurses. So we know when people are at the emergency department in transition. So we're able to follow up why. And we won't, and then the orange one is our community CSSL, which is our big flagship building in Burlington.
Oh,
Overlooks
Cathedral Square, yep.
It's
We're senior
Cathedral
living,
Square.
yeah.
And that also includes, I wanted to just pull out there, we have assisted living there. We have 40 rooms of assisted living. So those participants are included in this. And it wasn't a surprise to see that in 2023, it had spiked a bit. So we're keeping our eye on that. And this is also a trend that we weren't that surprised to see in 2022 with COVID, a lot less presentations, less people were going to the emergency department. We were hunkered in, we were doing our work at the buildings. So we're keeping an eye on that and the reasons.
I would also just add that the trending down is significant. Just want to say that. And just to be clear that what's most important to us at this point is that we are accurately tracking this and our team is working with those kind of what we call frequent flyers to the emergency department. And especially if we believe there's a mental health kind of underlying thing that's going on. That's a wonderful team-based approach that our group with the mental health clinician is able to bring to bear and working with those people that end up going to the emergency department because of anxiety or just a whole host of other things.
It would be great if they could get the care within their housing. Leslie has a question.
Yeah, I'm just curious, how many people are we talking about? What's the denominator?
Yes, good question.
It's just under 200,
Yes.
just under 200
So
people.
we have, actually it's 108.
There we go. Oh,
That's
okay.
the people that have signed up for
Okay.
the emotional wellness clinician. But
Well,
it's
no,
about-
I'm thinking about the ED presentations. I'm sorry, I want to be in the right spot. So you said 112 ED presentations, let's say in 2023. So how many?
It's in my notes on the slide.
Oh, good.
I don't
You know what I
have
mean?
the
So
notes right here.
Oh, it's on our,
Oh, never mind.
gosh, I'm so sorry.
We
That's a
can
good
follow up with
question.
that.
To understand the context, yeah.
Yeah.
Right, so you're wondering,
How many total people are enrolled in this program?
Yeah.
okay, so, yeah.
So there's 112 presentations, but that could be from 100 people.
Yes.
Or it could be 200 people.
500 people, right?
And 112
Just to
episodes.
see a little
The
impact.
next slide is gonna
Okay.
provide a little more.
Great.
Isn't it? Yeah. Oh, no, this is participants served.
Yeah, okay.
Yes. So do you want to cover that?
Yes, I do have to just say, well, sorry, I don't have that, but this is 108 participants are served by the SASH emotional wellness clinician.
Okay,
Um,
yeah, and the reason I said 200 is because the two buildings where we have it, we have roughly 200
People in the
participants
building.
all together.
Mhm.
Sorry.
But the tracking on the last slide is only for the 108 that are signed up for the program.
I can verify that.
Okay.
I don't, I have
Okay.
to say, I don't want
That's
to
great.
see that.
That's fine. Thank you.
We'll verify that.
Okay, great.
So you can see in 2023, Allison met with 108 people. Sometimes she met with them once and some people she met with 70 times. So it's just a matter of,
Wow.
and with the median visit of 6 counts for the year of 2023.
Mhm.
And what we also want to shout out is that 63% of our participants that identify as male have access services with Allison, which is compared to the national average of how many men seek mental health supports, and it's 12% in a study from 2021. That's really, I mean, it's just, we want to bash the stigma of like seeing a mental health clinician, right? So this is really, that's the biggest success is the.
And you've seen the big
access.
jump from 22 to 23.
Yes.
Exactly,
Yeah.
yeah. And, some of the range of visits, what's important is that the duration of the visit, it's not like, oh, it's 50 minutes, what a normal therapy session is, because Allison can meet with somebody for 10 minutes. She can meet with them for an hour and a half, because this is paid through this capitated model. So you can get those kind of visits for somebody, that person needed 70 visits, gosh darn it, and that's fine. Somebody else just needed 1 visit, and that's great. So that kind of flexibility and accessibility to mental health services, because she can come right to their apartment, or they can come downstairs to her office, or they can sit out on the park bench when they're smoking a cigarette. She does that too.
Right, right.
It's like, wow, that's above and beyond, but she will do that, So it's really that kind of flexibility that we think it's huge. Continue.
So at this point, we received funding from a congressional set aside from Senator Sanders, funneling through SAMHSA. So we're really excited to be able to expand this 2 panels in Burlington across the state. So we're partnering with Vermont Care Partners, and there's just a list up here of who we have contracts with and who some have hired and some are in the process of hiring.
Great.
Which is amazing, and working with our regional housing organizations. So just a minute.
Yeah, wonderful. And so how long is this funding
So
for?
it's a 1 year, and we have a second year anticipated through, Welsh.
If Congress does its job tomorrow.
Yeah,
Isn't it tomorrow that the budget?
Yeah.
If that doesn't happen, then, yeah,
Everything falls apart.
everything falls.
Robert?
A quick question. Well, when you list the sites,
Mhm.
Down Street in Washington County Mental Health, then you say, is that the town of Washington?
No,
Is that what that is?
Sorry, it is the county. So Washington County Mental Health,
Yeah,
It's a designated agency, right?
yes, is it.
and then it,
Then you say Washington slash
Montpelier, Evergreen and
Montpelier.
Waste.
Oh, that is the name of our panel. That's not to be confusing. Washington County.
And we have a panel right here in Montpelier, which
What's a
means.
panel?
A panel, I'm sorry, I was gonna say, we have a hub site, which is what in Montpelier, what's the name of
There's
the
River
housing site?
Station Apartments, and we work with the Montpelier Housing Authority in 58 Barry Street. And
Yeah, so the reason we use the word panel is because sometimes our staff are serving more than just one building, because a lot of our housing sites are not huge, so we pull together a couple, bring them together, and then the SASH team supports about 100 participants. So the Washington Montpelier panel is made up of a couple different housing sites and then serving.
like
some-
85
I
people.
get
Does
that.
that make
I'm
sense?
just trying to figure out what Washington is,
But it's meant for the county.
Yeah, it's just
Washington
referring to
County.
the
the whole county.
Yeah.
Okay. All right.
And just wanted to show you some of our baseline data that we've pulled with the participants that are in the panels that we talked about that are contracting with a designated agency to provide a SASH emotional wellness clinician. So we can see like this is a baseline around the loneliness scale. And this is also to show you a total of 27% of the participants are scoring as feeling lonely on the UCLA. And then how can that make a difference?
Right. And so next year,
Yeah.
27% to be much lower.
Yes, yeah. And also, I think it's just interesting for you all to see that, like, this is the data we're looking at statewide. And so we're able to say to, like, if you look at this, like, Decker Towers, they have a really high percentage of their participants are screening at risk of loneliness. So what's different there than ones that
Right.
have such a smaller one? And we get our staff together on a monthly basis to compare notes and talk about best practices. So this data is provided back to our staff on a regular basis. And it's about, again, kind of problem solving and best practices.
Here's the question.
Melanie?
This is great data and I really appreciate it. I don't see a Lamoille County in there. Is it just not doing, is it?
Not this
question.
time, right? So this is the first, so we're hiring to get funding to spread in 6 areas.
Okay. I just, especially because they were hit so heavily for the flood, I would be so
Right.
curious to know loneliness, suicidality, like some of the pieces of like.
Well, we can get you that data because we do have panels in Lamoille County
Okay.
for staff.
Yeah, certainly.
Yeah, they just unfortunately didn't have enough money to go into every single panel, so Lamoille did not get picked up for that, but we have the data, right? So
Yes.
we can share that with you.
I'm sorry, could you remind me what a panel is?
So I'm sorry, let me try to do a better job of explaining this. So the way that SASH is funded, we get so much money per roughly 100 people that we serve, and the money is to cover basically to cover the cost of the wellness nurse and the care coordinator. So what we do is we've distributed SASH across the state to housing organizations. And so they determine, okay, these are the housing buildings. Let's say it's Rural Edge. These are the housing buildings we're going to serve with SASH. And we need to get to roughly 100 participants because then we're going to have the staff to serve them. So like at Rural Edge, we have panels of up to 100 people that are living at like 13 different housing sites, not surprising. Then we have Cathedral Square Senior Living, the high rise In Burlington, that is one panel, one building, because there's close to 100 people that live there.
So people, it's panel based.
Exactly.
That's
I
70.
understand that. Sorry.
Yeah,
thank
no,
you.
great clarifying question. We start to use these.
Clarify what you said to me. So those embedded mental health supports are for those 6, and then you're hoping to expand that. moving forward.
Yes,
Other.
yeah.
I mean, ideally, it would be part of the new program that every panel would have it.
That's what we want, ideally. Yeah. Okay, no problem. Okay, so then we wanted to switch to talk about Sash for All.
Yeah.
Okay,
So everything up to this point
In the building.
is for people in the building, and there's mostly average age, I think you said was 73 or so.
yes. Okay, so Sash for All is still about being in the building. I want to clarify that. So we're still focusing on people living in subsidized housing throughout the state. And the main difference is that the traditional Sash was very much primarily to serve older adults and those with disabilities. But we have partnered with, 22 housing organizations across the state, including all of the public housing authorities, who have a lot of non-elderly housing in their portfolio. Cathedral Square is kind of the unique one in that that's kind of been our niche. So what we heard over and over again from our housing partners that were doing the traditional Sash is, when can we start doing this with our younger population? And it's something that we knew you have to be so intentional when you try to transfer a model to a different population. So we literally planned for about 3 years on how to do this. We didn't want to come in making assumptions about that this program will work for, 30-year-olds and children. So we did a lot of research, and we started piloting the model in the fall of 22 at 2 of our housing partners in Windham County, Brattleboro Housing Partnership and Windham Windsor Housing Trust. And you can see here the mission that we developed for Sash for All, working, with participants mainly under the age of 65, with families or without, doesn't matter, but a younger population. And really, it's really about, again, very similar to the foundational Sash model, which is strengthening well-being, improving health, and building that whole community. And I will say that homelessness prevention is absolutely baked into this model. And you'll see that as we talk more about it. So this gives you a little more sense of really what Sash for All is. And again, it is similar to the core elements of the Sash model. It's based out of housing. You have a staff team. We still have the Sash coordinator, and we have the wellness nurse. What we added into the Sash for All is that emotional, mental health support from the get-go. So we've baked that in. It's a little more expensive because of that. But you'll see, the wellness nurse doing the health assessments, providing coaching to individuals and families. We have the Sash team as well, bringing in the local partner agencies. The partner agencies look different with this population, and we'll show you who those partners are. But we're still looking for the panels, the populations that make up the panel, to really be part of a community that's really focused on being healthy and being safe and staying well housed. So these are the kind of 5 core elements of Sash for All, very similar to the traditional model. So you have the staff working out of the housing. It's person-centered approach. It's all in, meaning we want to focus on the entire population that we're serving. And at the same time, our staff do work with individuals on setting goals for what they want to achieve. And then again, we have these formalized partnerships. These are the current partners in the Sash for All pilot. So we have the hospital, we have the designated agency, we have a child and family development center as well, the Winston Prouty, which of course that wouldn't have been a traditional partner in traditional Sash. We have Turning Point, the Recovery Center. Cathedral Square is there because we're the statewide administrator. And then I know we're working for this year to add Brattleboro Retreat as well as the Community Action Agency into the partnership, right?
Jeanette White works for this group.
Oh, does she?
Yeah.
Oh, yeah.
Yeah.
Topper has a question. Yeah.
When you say Turning Point Recovery Center, does that mean all of them around the state or just one?
At this point, it's just the one in Brattleboro. This is a pilot only in Brattleboro for now.
Only in Brattleboro,
Yeah.
okay.
Good question.
Now, I want to get back to something because it's an area I represent.
Mhm.
Back earlier, you talked about, remember we had a discussion about Washington?
Oh,
And let's forget Washington. Early on in your presentation, you're talking about housing. And in that list was the Barry Housing Authority.
Yeah.
But then later on, I don't see it mentioned at all. Do you actually have staff in the Barry Housing Authority buildings?
oh, yeah.
I can't.
All
Let
We
her.
do. So we actually, that's a very strong SASH team at the Barry Housing Authority. The Downstreet Housing Community Development, actually, I only deal with, if you will, 6 housing organizations, and then Downstreet will fund Barry Housing Authority, like a funnel through,
of them? Okay, so the money goes to Down Street.
which
And
goes to
Barry Housing.
Barry
And to Barry
Housing
Housing.
and Lamoille.
That answers my
No.
question because I couldn't figure out how that would
They're
work.
Yeah.
Yeah,
at
but,
Barry
but,
Housing
but
Authority.
Barry Housing Authority hires their SASH coordinator, they contract for their wellness nurse.
Yeah.
So they absolutely, they're an incredibly strong, SASH team, and they've been operating for many, many years now. So.
Yeah.
Great,
That's
thanks for
Thank
that,
you.
thanks for that follow-up.
Just a quick question. You mentioned wanting to avoid homelessness, like that's a real crucial piece of your work. Do you have a sense of how many people end up homeless because they can't sustain in your program?
We don't track that. I mean, this year, our administrative team, this is for the older adults. This is slightly new, with what we're supporting. We have 139 staff around the state. I say we, but they're not hired by us. So we do, but we haven't tracked that on the SASH side. Certainly those housing organizations could tell us that.
We are tracking for this pilot, we are keeping track of, evictions and, the work the staff are doing to prevent evictions. So that's where we really kind of honed in on homelessness prevention from the get-go. We have a housing instability, survey that is part of the assessment in this that we didn't have as part of the original SASH. So those are the kind of changes we did in that planning phase for SASH for All.
Thank you.
Art, and then Dr. Art, I want to make sure we keep going because there's quite a few, but go ahead, Art.
Yeah, just quickly,
Mhm, of course.
where do you folks fit in with the other folks that are home health people?
Mhm.
Where do you fit in the whole process?
That's a great
Yeah.
question, because our wellness nurses they're preventative nurses. Our nurses work with the home health and hospice nurses. They're actually part of our structure is a memorandum of understanding that the whole state, including those that represent all the home health agencies and the mental health agencies, sign on to. So we collaborate and we streamline, so we're not duplicating our services. So it's different functions, if you will.
Well, how is it different?
So our wellness nurse is actually 10 or 20 hours a week at a panel at a building, doing their assessments. We don't for medication, for example, but we'll ask about medication adherence, doing the work that a skilled nurse who isn't doing more education, long-term planning with that participant for year over year over year versus like episodic touch of a nurse. It's a different kind of nursing.
Yeah, and I think that a good example, so this is a great question, because
Yeah.
it can be confusing, but a good example, I think, is if we have a SASH participant that's in the hospital and had like hip replacement, they go home and they get a skilled nurse referral to the home health agency. So they have a nurse that's coming out to see them at home as they're going through their first few days or few weeks of recovery from their hip surgery. At some point, the skilled nurse from the home health agency is done because the person has hit, the person has come to a place where they don't need those kind of skilled services anymore. So what happens then is the skilled nurse and the wellness nurse that's with SASH meet together and they kind of do this handoff and say, okay, so I'm the skilled nurse. I'm not coming anymore because we've hit our targets, but our shared patient could use reinforcement with this, that, and the other thing. And so the wellness nurse who's at the site regularly will go in and check on that person. How are your meds doing? Are you keeping up with the physical therapy? Do we need to make a call about that? So it's this warm handoff. And what that does is it reduces hospital readmissions. because of that. And that's what our data for SASH showed, is that we reduced readmissions and ER visits.
Okay, and these people are all at a facility that you would do this for?
So they're in
They're like
apartments.
private apartments.
Okay.
Yeah.
Yeah, and some live out in the community. It's a smaller percentage. So we are able to serve people.
You
that
are able to
Medicare.
serve
Yep.
people in.
Oh, yeah. Yeah, they're on Medicare. They have to be on Medicare. So yes, we do have
Be on Medicare.
Yeah. great questions. Okay, should I keep moving?
We'll shut up.
Oh, no. We just wanted you to know how SASH for All, the 2 pilots have been funded. Initially, we were funded, this is when we started in September of 22 with, again, a congressionally directed spending allocation from Senator Sanders. Then last year, thank you very much, we got an appropriation from the legislature to continue for year 2 of the pilot, and that's what we're in right now. So that money is being funneled to us through DALE, Disability Aging and Independent Living. And we also got a small private foundation grant last year to really hone in on how is this, the pilot's been happening for a year. What are the lessons learned? How is our evaluation framework holding up? What do we need to tweak and pivot with? Because we have 2 amazing consultants. One is Representative Emily Kornheiser that worked with us all last spring and summer on this. And so that's been wonderful. And then for next year, which would be year 3, so starting next fall, we have gotten a private bank foundation to fund us $450,000, but that's going to be over 3 years. And so that we're short. So we are going to be again asking for a legislative appropriation of just $300,000 to get us through year 3 of this pilot. And then our long-term goal, and it's important that you all hear this as the healthcare committee, is to get SASH for All, like the traditional SASH model, included in the all-payer model, the next version of the all-payer model, which we think is going to be something called AHEAD. So we are working very closely with the state and DEVA and been very clear that that's where we believe this should land because it's saving healthcare dollars and we think that's the right pocket for it to come out of. Okay, do you want to touch upon some of these?
Yeah.
Or should we?
Just really, really briefly, we have contracted with Maggie Foley Consulting, probably just mentioned that,
Yeah.
on diving in to see how we're doing as we go and adapting the pilot to make the most impact as we can. And this is how we're doing it, what we're measuring, with only 5 minutes left.
We just want to make sure.
Take your
time.
Yes, so.
We just want to make sure you understand that we have a very rigorous framework
Yeah, we
around
do.
evaluation.
I think we should shout out too that our education with all of our staff, our onboarding is based in the strengthening families modality for this pilot versus the traditional SASH.
Good point.
And this is just so lovely, just showing you.
Because last year, because it's not quite Valentine's.
Yeah,
Day.
and our, and the team there, right, just help the kids make that.
Yeah. And then we did want to just make sure we shared, just to give you a sense of who the pilot is serving right now.
Yeah, so when we say how many participants we have, they're all adults. And then we add the children. So at this point, 153 people, 80 adult participants, 70 dependents. Not too different, our gender demographics based on our traditional, but I mean, the race demographics were more diverse than the state of Vermont and what we're seeing at the traditional SASH, which is interesting.
Yeah.
Who we're reaching. We asked on our assessment, the assessment's different. We went through a year and we're still updating this assessment. How hard is it for you to pay for the very basics like food, housing, medical care? And if you add up somewhat hard and very hard, that's that 70% of our participants find it hard.
And these are people, remember, that are in subsidized housing. So there are, so even with that break, it's so hard for them to get by.
Yeah. We ask about food insecurity, and that's another great connection that we make in traditional SASH is providing food and food resources to our participants. How would you rate your health?
That's a little scary.
Isn't it?
Yeah.
None of them say very
These
good.
are younger,
Yeah.
and these are younger people.
Yeah. Do you feel like you're reaching your intended target
Population. Absolutely. Absolutely.
Out of the first year, we didn't have a lot of people we're not doing the assessment, we're building relationships and our teams are talking with the kids, how do we get buy-in and doing different, just building our relationships with the residents in the Brattleboro area. They're doing a great job.
And it's all voluntary. No one's required to
Yeah.
join this program.
If
so.
you, even if you sign up for Sash for All, you do not need to do an assessment, but we find that most people do. And once they talk about it with their wellness nurse, they're like, oh, and they come back and then talk more, and it just kind of builds. I mean,
Wait, before you go forward, do you have this data for those in the standard SASH program?
Yeah.
Could you get that for us?
You want it statewide? Like, or do you want particular panels? Because we can,
No, statewide number will be fine.
yeah, we can.
it's kind of indicators.
Yes.
Right, and all of them, they're all in Medicare. Right?
Some are dually eligible.
Some are dually eligible.
Some are on
Mhm.
Medicare. Yeah.
Okay.
We can pull some data like.
And then are there, for the low income housing that they're in, I'm assuming there's income requirements to be in those homes. Could you also get us that
So
information?
the challenge there, Chair, is that the funding sources are going to be varied all over the state. We can certainly tell you kind of the top
Average.
ones or something like that.
Yeah,
Okay, but
that's
there
fine.
are like, because there's so many different federal and state funding sources with different income eligibility, so
Right.
that can be a little hairy.
Yeah, I just want to, so we're working on another bill about expanding Medicare savings programs. And some basic, so I think this data would be helpful to talk about that, because
Tell that
it's going to
story.
be the same population, a lot of.
Very low income. Yeah, absolutely.
So that would be helpful to have that at some point. I think.
Again, we have. The one thing I want to just point out, because you are the healthcare committee, is just, we are collecting health data on this younger population. And what's really, I think, so powerful about this, if we're finding participants with hypertension or pre-hypertension, our nurses can get in there and start working on that. And so that they don't have to be 70 with hypertension out of control, that we can work with them and they're in their 30s and their 40s. Diabetes management, where the nurses are working with women on making sure they're getting their mammograms regularly. I mean, all this preventative stuff, and getting it when folks are this young and they have their children seeing that, yes, you go and you get screened, I think is just so powerful.
Great.
And these are just some of the early outcomes we wanted to share with you from the first year.
Go ahead, Alan.
What did you do to avoid 10 evictions?
We got over 12,000 bucks, but to help for the back rent.
Okay, so,
Some of the B rapid.
so it was negotiating and
Yeah, and like a lot of people, they, don't know of the specific, that they can get back money, and then when, that kind
I
of-
mean, that's the quick answer, but a lot of it is around that relationship building and people getting, the staff getting them connected to financial literacy.
A lot of housekeeping
Yeah.
help.
Yeah.
There were some stories about that the staff was telling.
Yeah. So there's a lot of stuff. And we're also seeing some early reductions in emergency department visits, which doesn't surprise me.
Right, and that is really great data to have, because that that is such a high cost of the system to prevent that.
And this is why we really do think all pair model or
Right.
whatever it's going to be is the right source, like it is for traditional SASH.
Right.
But we would appreciate it if this committee would consider being supportive of another state legislative appropriation to get us through
Right.
year 3 of the pilot, which is, if you can get 3 years of program under your belt, that's when a model usually starts to sing. You have enough data to know what's working, what still needs to be tweaked. So
So I think that appropriation normally goes to the Human Services
Yes.
Committee, but I'll talk to Teresa.
yeah, and I just want to make you guys aware that we are and we're talking to people about that
Okay.
and a House approach.
Okay, great. Great. Thank you. This is great. Topper?
The people that work for you in these different places, all the people that go into individuals' homes, what's their responsibility in terms of reporting if an elder is being abused?
Yes, we train and we're mandated reporters.
Mandated
One
reporters.
one of the administrative parts of us is we ensure people are trained up, all of our staff are trained up, and I say staff, again, Barry Housing employs their own staff. We're just supporting that. We're supporting that with this program. In addition, HIPAA training, we make sure everyone has that every year, because these are housing staff and it's not in our, wheelhouse all the time. So we're just like doing those sorts of things. And also with the SASH for All, we did similar.
Okay, so every housing authority has their own staff. all they get
But we do,
is money.
yes, but Cadito
Yeah.
Square as the statewide administrator for SASH does all the onboarding training with SASH staff, whether they're hired by Berry Housing or Lamoille Housing. So all the staff across the state that are doing SASH are trained the same, they're using the same data management system, they're coming to monthly meetings to
And we
hear
have a
from each
month,
other.
yeah, monthly, we have a health systems educator, a registered nurse who works with the nurses on, we have monthly webinars,
Yeah.
interventions. So there's a lot of support and consistency in how we want to roll out this program.
They do a wonderful job.
Yeah,
I,
it
I,
is.
I notice,
Thank you.
in Barry Housing Authority, that, the drug dealers are going in there and trying to co-opt these elderly people.
Oh, yeah.
And they end up living there, they get the elderly people hooked. It's a pain in the
It's
neck.
not just happening in Barry, I can tell you that.
Mhm.
It's not just happening in Barry, I can
Oh,
tell you
sure,
that. Yeah,
sure.
it's really,
I'm just
it's,
familiar with that.
yeah.
It's terrible.
I would encourage people who haven't gone to a SASH program in their local community to do that. I'm sure Molly or Liz could help you arrange something, but it's great to see. It's great to talk to the participants and hear the services they're getting and how it's helping them. And it's really pretty powerful.
Great. Well, thank you so much for your time. I really appreciate it.
Thank you, both. Do we have?
We'll follow up with that detail.
Yeah,
We'll go off air for a couple of minutes until our